asked to speak to the group, please press *6 on your phone to unmute and mute. If you are using your laptop for audio and visual during the meeting, you can control the mute function on the Hangout. We kindly ask that those who are speaking to the group unmute their device. For DUR board members, reserve the question until the end of the presentation or may ask in Google Hangout meeting chat. For public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicaiepharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information regarding your name, email, and the company in the Google Meet or chat, or email medicaiepharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after meeting to help us improve our process moving forward. And thank you for joining us today.
Thank you. Can you hear me okay?
Yes.
Great. Good morning. Hope everybody's doing well. Do we have a quorum?
Yes, I think we do have a quorum.
Excellent. Okay, so you already got the reminder about submitting contact information via Google Chat or email. And so has everybody had a chance to review the minutes? Are there any corrections? Hearing none, is there a motion to approve the minutes?
I move that we accept the minutes as drafted.
Second.
Thank you. All right, all in favor of approving the minutes, say aye.
Aye.
Any opposed? Okay, the minutes stand as approved. Thank you very much. Okay, the next item on the agenda is the P&T committee update.
Good morning. So in the month of November, the P&T committee reviewed immune globulins. And our next topic that we'll be reviewing in February will be continuous glucose monitoring. And we're pretty excited about that topic. Another thing that I was asked to mention is sort of some background on this meeting. When we're looking at topics in DUR board, we're primarily focused on safety and efficacy, and that remains the case. On occasion, when all things are similar with regard to safety and efficacy, we may also consider cost. And so that's one of the issues today. We're not going to be discussing any numbers, any specifics about cost, about any of these drugs, but the drugs that we are discussing are, we'll say, costly. And under Utah Code Title 26, Chapter 18, Part 1, Section 2.3, it states that the division is responsible for the effective and impartial administration of this chapter in an efficient, economical manner. Also that we're to establish on a statewide basis a program to safeguard unnecessary and inappropriate use of Medicaid services, excessive payments, and unnecessary or inappropriate hospital admissions, lengths of stay, et cetera. And so, again, that's a charge to the division, not necessarily the board, but we do have a responsibility to make the best use of limited funds. And so again, we want to focus on the clinical factors, but keep in mind that the drugs we're discussing, there are cost considerations as well. And that'll yield the time.
Great, thank you, Brian. Okay, the next item on the agenda is the discussion on newer antipsychotic agents. Do we have a presentation from University of Utah?
Yes. Dr. Heath, could you present?
Yes, hopefully this will work. 1 second. All right, can everyone see my screen?
Yes, we can.
Awesome, thank you. All right, so this DUR report presentation focuses on 3 newer oral second-generation antipsychotics, brexpiprazole or Rexulti, cariprazine or Vraylar, lumateperone or Caplyta, that are all non-preferred on the Utah Medicaid Preferred Drug List, or PDL. This report presentation aims to provide more information about indications, comparative efficacy and safety, and guideline recommendations for these newer oral antipsychotics to help understand a potential place in therapy. Metabolic side effects such as weight gain, dyslipidemia, and hyperglycemia are a known side effect of many second-generation antipsychotics, and this report also aimed to review the relative propensity for metabolic side effects of the newer oral antipsychotics compared with other second-generation antipsychotics. Our goal in presenting this information is to consider the appropriateness of implementing additional steps such as prior authorization criteria for these products. All right, so this table provides an overview, a broad overview of FDA-approved indications and potential off-label uses recognized by compendia and/or clinical practice guidelines for oral second-generation antipsychotics. To orient you a little bit to the table, generic drug names are shown on the left, while indications or PDL placement are shown at the top. An X indicates an FDA-approved indication, while the double slash indicates a potential off-label use. The A and M abbreviations also indicate primarily FDA-approved indications, with an A referring to use as an adjunct to lithium or valproate, and M to indicate monotherapy. Focusing on this first column, you can see the newer oral antipsychotics are not currently preferred on the PDL, but a number of other oral antipsychotics are on the PDL. Most second-generation antipsychotics, including brexpiprazole, cariprazine, and lumateperone, share an indication for schizophrenia. Brexpiprazole is also indicated as an adjunct to antidepressants for major depressive disorder, which is an indication shared by aripiprazole and quetiapine extended release. The olanzapine fluoxetine combination is indicated for treatment-resistant depression. Cariprazine is indicated as monotherapy for bipolar I disorder, acute mania, or mixed features, and for bipolar I depression. Several other second-generation antipsychotics that are preferred on the PDL are also indicated for acute mania or mixed features, either as an adjunct to lithium or valproate or as monotherapy. Fewer second-generation antipsychotics are indicated for bipolar I depression. Those with indications include lorazepam, quetiapine, and olanzapine fluoxetine. Cariprazine is not approved for use as maintenance therapy for bipolar disorder, while some other second-generation antipsychotics are approved for this indication. Finally, in the last column, you can see that brexpiprazole, cariprazine, and lumateperone are not yet indicated for use in pediatric patients. Guidelines reviewed consider all antipsychotics to be generally similarly effective for the first episode psychosis and the treatment of schizophrenia. One guideline prefers starting a second-generation antipsychotic over a first-generation antipsychotic due to a better side effect profile and possibly better relapse prevention. Clozapine is recommended for treatment-resistant cases. Selection of an antipsychotic is driven by patient-specific factors, including patient preference, the anticipated side effect profile, available formulations, pharmacokinetic considerations, comorbidities, and prior treatment response for those that are not treatment naive. Most guidelines recommend continuing the same antipsychotic for maintenance treatment if it was effective and well tolerated during acute treatment. Information about lumateperone was not available to be included in the guidelines reviewed, but information about cariprazine and brexpiprazole were included. Treatment of bipolar disorder includes an acute phase to treat an emergent mood, such as mania or depression, and a maintenance phase, generally at euthymia, as prophylaxis to prevent relapse to depression or mania. Treatment is selected based on treatment goals, patient preferences, treatment history, side effect profile, and patient comorbidities. Similar to schizophrenia, if a treatment is effective and well tolerated during acute treatment, some guidelines recommend continuing the treatment for maintenance treatment. However, not all treatments that are used acutely have supportive evidence for preventing mood recurrences during maintenance treatment, so providers should also consider this when selecting a maintenance treatment. For the treatment of bipolar I disorder in adults, second-generation antipsychotics are among first-line treatment options for acute mania, depression, and maintenance treatment. Other major treatment options include lithium, valproate, carbamazepine, and lamotrigine. Antidepressants may be used cautiously due to concern of inducing a switch to mania under certain circumstances. Note that in the 2018 CANMET and ISBD guideline, both lithium and valproate are among other first-line options for mania and maintenance treatment. Carbamazepine is a second-line option, and lamotrigine is among first-line options for depression or maintenance. Compared to mood stabilizers such as lithium and valproate, antipsychotics may be effective quicker, which may be advantageous for some patients. In guidelines, lithium is generally considered a gold standard for maintenance treatment of bipolar I disorder due to the most robust evidence of benefit in preventing manic and depressive episodes. Lithium also has some evidence supporting a reduced risk of suicide. This table shows second-generation antipsychotics recommended among first-line options for treatment of bipolar disorder. The only guideline reviewed that was published at a time to include cariprazine, the CANMET guideline, includes cariprazine among first-line options for bipolar I mania, and several other second-generation antipsychotics are also recommended for this, as shown in the first row of the table. Fewer second-generation antipsychotics are among first-line options for bipolar I depression. CANMET includes cariprazine as a second-line option for bipolar I depression. Combination treatment with a second-generation antipsychotic and lithium or valproate are also among first-line options, usually in patients with a more severe presentation or a history of partial response. Guidelines for both schizophrenia and bipolar disorder state that the side effect profile of antipsychotics should be a factor in selecting an initial treatment and for later changing treatment. Various guidelines, particularly the 2016 British Association of Psychopharmacology guideline about managing metabolic side effects, includes different strategies for managing antipsychotic-induced weight gain as shown here. One option includes switching to antipsychotics with a lower risk for weight gain. Guidelines consistently classify clozapine and olanzapine as antipsychotics with the highest risk for metabolic side effects, and various antipsychotics, including both brexpiprazole and cariprazine, as among those with lower risk. Antipsychotic-induced weight gain is proposed to occur in 3 phases. During phase 1 of the first few months, rapid weight gain may occur. In stage 2, which may occur over 1 or more years, slower but steady weight gain occurs. And stage 3 is a plateau where a patient maintains that weight. The time to reaching this weight gain plateau may vary by antipsychotic. Clinical practice guidelines note that early weight gain, such as in the first 6 to 8 weeks of treatment, generally predicts long-term weight gain. First-time antipsychotic users and/or younger patients may be more sensitive to gaining weight. Regarding comparative efficacy, in a systematic review and meta-analysis of antipsychotics for the short-term treatment of multi-episode schizophrenia, brexpiprazole and cariprazine were overall similarly effective to other second-generation antipsychotics. Some differences between cariprazine and risperidone have been noted. Direct comparisons meta-analysis found a statistically significant benefit for risperidone over cariprazine for overall symptoms and positive symptoms. The quality of evidence for these comparisons was rated as low or very low. In one unique 26-week randomized controlled trial of patients with schizophrenia and predominantly negative symptoms, cariprazine outperformed risperidone for change in negative symptoms. Lumateperone was not included in identified systematic reviews. 2 clinical trials for lumateperone included a risperidone arm as a positive control, and lumateperone seemed to be similarly effective to risperidone in one of the randomized control trials, but not the second trial. For treatment of bipolar disorder, systematic reviews did not include head-to-head comparisons with cariprazine. Indirectly, the effect size for cariprazine versus placebo for mania seems similar to other second-generation antipsychotics. Indirect comparisons of cariprazine to other second-generation antipsychotics for bipolar depression is uncertain. Cariprazine may be similar to other antipsychotics based on overlapping confidence intervals, but the number needed to treat is slightly higher. This slide shows a comparison of relative side effects among second-generation antipsychotics, mostly based on indirect comparisons of short-term data from network meta-analysis in patients with schizophrenia. There can be considerable patient heterogeneity, and this should be viewed as a rough comparison. More plus signs indicates greater risk, and the combination plus-minus sign indicates the lowest risk. Red highlighting shows those at the greatest risk in that column. The first 4 columns show various metabolic side effects. From this, we can see that the newer antipsychotics appear to be among the agents with the lowest risk of weight gain, hyperglycemia, and dyslipidemia. Brexpiprazole may have a slightly higher propensity for weight gain. Cariprazine is among second-generation antipsychotics with the highest risk of akathisia. There is limited data for lumateperone, but preliminarily it seems to be among those with the lowest but not negligible risk for metabolic side effects. Aripiprazole, lorazepam, and ziprasidone are also among the second-generation antipsychotics with the lowest risk of metabolic side effects. Lorazepam is among those with the highest risk of akathisia, and ziprasidone has the highest risk for QT interval prolongation. Knowledge of the risk of potential long-term metabolic side effects are more limited for the newer oral antipsychotics, particularly for lumateperone. Warnings and precautions on product labeling for the newer oral antipsychotics are similar to other second-generation antipsychotics with the same FDA-approved indications. Some more unique warnings include a black box warning for suicidal thoughts or behavior in people 24 years of age or younger treated with antidepressants, included for both brexpiprazole and cariprazine. The possibility for delayed onset of adverse effects with cariprazine, and risk of compulsive or impulsive behavior with brexpiprazole, similar to aripiprazole. So, in summary, reviewed guidelines and efficacy data suggest that newer oral antipsychotics do not have superior efficacy to other second-generation antipsychotics for the treatment of schizophrenia and probably for bipolar disorder in the case of cariprazine. They do offer an additional therapeutic option for some patients. For example, cariprazine for the treatment of bipolar 1 depression, where there are fewer treatment options. Indirect comparisons of metabolic side effects suggest that the newer oral antipsychotics have a lower risk than other high-risk second-generation antipsychotics, such as olanzapine and clozapine. Review data primarily of a short duration suggests that each of the newer oral antipsychotics are among the second-generation antipsychotics with the lowest propensity for metabolic side effects. However, their risks for metabolic side effects have not been clearly differentiated from other second-generation antipsychotics also considered to have a low risk for metabolic side effects, such as aripiprazole, lorazepam, and ziprasidone. And limited long-term information is available, particularly for lumateperone. Currently, all of the uses for which the newer oral antipsychotics are indicated have other preferred second-generation antipsychotics available on the PDL. Among these products, several are also considered to be among antipsychotics with a lower risk of metabolic side effects and guidelines, such as aripiprazole, acenapine, lorazepam, and ziprasidone. Though lorazepam does require a trial and failure of another preferred antipsychotic first. Creation of prior authorization criteria for the newer oral antipsychotics may be considered. And thank you for your time.
Thank you. Are there any questions from the committee? That's good. Very straightforward.
Excellent.
So, and I assume are there no guests interested in speaking today? Is that correct?
Yes, we don't have any public comment today.
No public comment. Okay, great. Okay, so next steps are what? Do we have a form to go through, or?
We don't have any today. It would just be the board discussion and question.
Gotcha. Is this something the board would like to consider for the future? Any thoughts?
I think considering prior authorization criteria makes sense, given there's not clear rationale based on the data that we have to support why these newer agents should be on the preferred list in place of other agents that are generic and seemingly equivalent.
So,
I agree. Go ahead.
are you proposing criteria for such where data is not clear or not available? Is that what you're talking about?
I was just saying, I think it is worth us considering in the future what those criteria could be.
Good. Good idea.
This is Joe. I had a question for Lauren. Lauren, you touched on some of the movement disorders, and I am not quick enough to see that or to follow that slide, but is there any difference? I mean, you mentioned weight gain, that there's, and diabetes, that there's some striations or stratifications of the various agents. Is there a similar sort of different groups relative to the side effects of movement disorders, akathisia, tardive dyskinesia, et cetera?
Let me see if I can share that slide again. That might help you. But cariprazine does have maybe a higher risk of akathisia compared to some of the other products, although that is somewhat dose dependent. So at lower doses, it's less frequent. You can see lorazepam also has a high risk of akathisia. So for the other newer agents, risk of akathisia might be a little bit lower. For Parkinsonism, which was measured by use of medications to treat that, these products are similar, I would say, to other agents that are included on here. The data I reviewed didn't include a comparison for like longer term risks, such as tardive dyskinesia. So we don't have information about that at that time, or at this time, at least compared to other second generation antipsychotics.
Okay. And thank you. I probably should ask Dr. Weinstein too for her input on that. So, I'm sorry, Dr. Siegfried. Sorry, Dr. Siegfried.
In terms of the tardive dyskinesia, it seems that second generation antipsychotics may confer a lower risk than first generation antipsychotics. However, other than clozapine, there really is no long-term data that compares antipsychotics head-to-head in terms of the development of tardive dyskinesia in second generation antipsychotics.
Thank you. Thank you.
Excellent.
Hi, this is Craig Hummel. One of the things we're finding is that the Vraylar is used a lot in the industry. The community standard, I believe, is pushing towards using Vraylar for bipolar depression, and interestingly, there aren't a lot of people who are using this drug, but it is increasing in the use of bipolar depression, and people seem to be moving away from Seroquel, and they seem to be moving a lot away from fluoxetine, olanzapine, which I personally think is wise. But I don't know if someone can comment on that, because if the community standard, which is something we measure and take into account, is the use, would we keep that on the put that on the preferred drug list or not?
So now, granted, I mostly have exposure on the pediatric side, but I do have adult colleagues that I work with. And I would say that lorazepam is usually what folks are going to for bipolar depression, because we have more data for that. And it looked like that was on the preferred. And I always get a little nervous when we see more of an uptick in these newer drugs, because I wonder how much like marketing, samples, those sorts of things are playing into the use of those medications versus clear data that they're more effective.
I would agree with Elizabeth. I see more use of lorazepam, and it also is, patient dependent. Some patients may have comorbid insomnia or anxiety where Seroquel or quetiapine may be more appropriate, and also combining it with medication such as lamotrigine over the olanzapine, fluoxetine, either fixed combination or using each as a generic.
Yes, I would also agree that lamotrigine is a common medication that we see.
Great.
I think
the
committee might want to consider at least some sort of step-through therapy, such as you do with the lorazepam, depending on whether or not you want to place it on the PDL or not. If you don't want to place it on the PDL, then you may want to do something, a bit more, elaborate in terms of, sticking with the FDA indications, and maybe failure of, a certain number of other agents, depending on the indication, as something to consider for these newer medications in the future.
One thing that may be worth
Yeah,
keeping in mind with
I
these medications is that they are already on the preferred drug list as non-preferred, with the exception of Latuda, which is preferred with step-through. However, for all of the mental health medications, there's a DAW provision that allows, if there's a
Explain how that works. I'm sorry.
What's that?
I'm sorry.
Could you
Yeah.
explain how that works?
Yeah. So, well, there's also a dispense as written override. So if a doctor writes dispense as written on the face of the prescription, then and the pharmacy bills DAW1, then even if a medication is non-preferred on the PDL among the mental health drugs, then the claim will process without a prior authorization.
So is that what you meant by step through?
Step through is just a little simpler for the Latuda. So if a patient has previously received a different antipsychotic, then they get a prescription for Latuda, it'll automatically process because the system will recognize that they've already tried something else. Or if there's been a claim, right, a preferred agent. And if there have been claims for Latuda, then it will recognize that, okay, there is a recent history of Latuda and claims will continue to process. So that's how the step through works on that one.
So is it, do folks think we need to put these newer agents on some kind of a PA at this point, I was asking, or no?
I think we were talking about doing that in the future, maybe near future. Okay, any other comments? Thoughts, questions? All right, I think we are out of agenda items.
Okay,
So, go ahead.
Was that a yes or a no?
Yes, that we are going to discuss it at a future meeting. There were several people.
Okay, thank you. I apologize. My laptop
That's okay.
decided to close down as I was trying to log in this morning, so I'm on a tablet and I didn't. It's, my audio's not great. Thank you.
Yep, no worries. So our next meeting then is January 14th, 2021. So this is the last meeting of the year. So I hope everybody has a great holiday, great New Year's, and we will see you next year. Is there a motion
Thanks,
to
team.
adjourn?
Move to
Motion to
adjourn.
adjourn. Second.
All in favor?
All in favor.
Stay safe out there.
Happy holidays, everybody. Stay safe.
Happy
You
holidays.
guys.
Happy
Thank you.
holidays.